Okay, so it is 6:05, so I'll go ahead and start the meeting. So welcome everyone, bienvenidos a todos. My name is Jennifer. I'm one of the MOLA interns. MOLA thanks you for attending the COVID-19 vaccination event. So this event will be broken down into 3 segments. So there's going to be a public health portion, one that focuses on the scientific aspects of the vaccine. And at the end, we'll have an all Spanish section discussing like common myths about the vaccine. The meeting is recorded. We will have like a general QA session at the end, about 10 minutes. So if you can please send me, so just look for Chicago MOLA and send the questions directly to that. So I can just jot them down so we can then bring them up during the QA section. And yes, I'll pass it now on to Erica, who will be presenting our presenters.
Thank you, Jennifer. My name is Erika Arias, and I'm one of the moderators. And I'd like to start by introducing our speakers. So first we have Dr. Luna. Dr. Geraldine Luna is the Medical Director of the Chicago Department for Public Health in the COVID-19 Response Bureau and Director of the Executive Board of the Medical Organization for Latino Advancement, or MOLA. She's been practicing medical care for more than 10 years, focusing on geriatrics and internal medicine. And she has both board certification in geriatrics and internal medicine. In addition, she has her master's in public health and is currently a student in the Executive Master's in Business Administration program at Kellogg School of Business at Northwestern University. Next, we have Dr. Shanjani. Dr. Lourdes Shanjani is a bilingual, English and Spanish, and bicultural international medical graduate. She received her medical degree at Universidad Autónoma de Santo Domingo in Dominican Republic. She also holds a Master's of Science and Health Sciences with a double concentration in health education and public health. Dr. Shanjani has over a decade of experience working with underserved communities in both the US and Caribbean, providing direct services as well as designing, managing, and fundraising programs that benefit immigrant communities. She currently serves as the Bilingual Health Education Coordinator at the Public Health Madison and Dane County, where she provides leadership for public health staff and community partners to assess, develop, implement, and evaluate health education programs and services to meet community health priorities. And last but not least, we have Dr. Zambrano. Dr. Carlos Zambrano is a physician in Chicago who trained in internal at AMITA St. Francis Hospital in Evanston and in infectious disease at Northwestern Memorial Hospital. He has 20 years of experience working as an independent consultant in infectious disease in Chicagoland area. Dr. Zambrano also practices infectious disease. So now I'd like to hand it off to Calvin, who will introduce the moderators.
Hi, thank you so much, Erica. Good evening, everyone. So I'm going to start off by saying my name is Kelvin Caldwell. I'm a pre-PA student, and I'm currently a member of MOLA's Public Health Committee. Erica Arias, the wonderful moderator who introduced the doctors, is a third-year MD PhD student at Northwestern. She's been a MOLA member since her first year of medical school and is a part of the Advocacy and Public Health Committee. Yanina Guevara is a third-year medical student at Chicago Medical School at Rosalind Franklin University. They are MOLA's co-chair for the Advocacy Committee and one of MOLA's 2020 scholars. I'll be handing it back off for Erica as she introduces the first segment.
Gracias, Kelvin. So I'd like to first thank the audience and speakers for joining us tonight. And we'd like to start the discussion on equal access to vaccination. So while the creation of the COVID vaccine was no small hurdle, distribution is an enormous challenge. And COVID-19 has disproportionately affected several populations, including the Latino community. So it's important to address these gaps in distribution and the shortcomings of our healthcare system if we want to achieve widespread vaccination in our community and save lives. Tonight, we're really grateful to have Dr. Shanjani and Dr. Luna to discuss the vaccination rollout in Chicago and Madison and Dane County and how these places are working to address equal access to vaccination. So Dr. Luna, Dr. Shanjani, what are the logistics in deciding how to distribute the vaccine and what type of vaccine goes where?
Okay, I can start. Thank you everybody for having me. It's a pleasure to be here today. And I would say the logistics here in CDPH, which is the Chicago Department of Public Health, it's very complex because this is the first time that we, in our era, that we have faced a pandemic. and the size or the efforts and initiatives that have to be put in place are overwhelming. So what we have been doing here in Chicago is partnering with already our health systems that they're very prepped in the infrastructures of vaccinating our population every year. And we have paired with pharmacies, which have been not pioneer, but taking like champions in vaccinating our residents at the nursing homes and long-term care facilities. And the city, as always, takes care of those that are vulnerable, and it jumps in just to fill the gap. So that's what we've been doing. The first part of the vaccination strategy is 1A, which is healthcare providers and also residents in long-term care with the personnel of these places. So we're talking about workers. If you see the logistics of the rollout is workers, workers, workers. And so we have taken those that are higher risk and more, and those that are also at risk of dying secondary to COVID. And because of the nature of their job, they're exposed to COVID, even if it's at the COVID unit or it's the emergency room or any COVID products that they are exposed to. So we're taking those upfront. And right now we're almost finishing. I mean, we're talking about 400,000 of employees here in the Chicago land alone. So it's taking more than a month, as you can see. And we're expecting that it's going to be overlaps while we move to 1B, which is going to be the workers, essential workers for first line. And as you can see, all of these that I'm mentioning are overrepresented by Latinos. So that's the population that we want to talk about today, because we're dying, and we're dying high numbers. In terms of the pods, what we're taking is any of those healthcare workers that are not affiliated to any of these hospital systems, or they're not affiliated to the pharmacies, and those we are providing services to. We also have, for example, healthcare workers that are not affiliated, we're talking about home health care that are not affiliated. So we're talking about big agencies that either they're becoming providers and not provided vaccinators. And then what we do is provide them with the support, with the logistics, the transportation of the vaccines, and we provide it to those facilities and they can vaccinate. They become vaccinators. And the other thing that we're doing is strike teams. So if we have a place that is very difficult for the people to move from that place, sometimes it makes more sense if they don't want to become vaccinators, that we go there and we take our strike team and we vaccinate everybody at that facility. That strategy we're doing too. In turn, our pods is a point of dispensation, which is the clinics that we're giving massive vaccination, and it's going to be moving quickly to the public now that we move down our prioritization list. So those we have personnel, and we're subscribing volunteers to keep up with the population that we're planning on vaccinated, and we're vaccinated right now. Any of those healthcare workers that are not affiliated to these healthcare systems that I mentioned, or pharmacies, or they're uninsured, or there's other conditions, keeping them from having equal access to health. So I don't want to take over the conversation. I'll leave it up to Lourdes now.
Thank you, Geraldine, and thank you to everyone that is tuning in tonight to listen a little bit more and learn about how the vaccine is being distributed in different places. So, as Dr. Luna was referring to, the process of the vaccine allocation and the tier or phases of this distribution are recommendations that come from the federal and the state level. And for us at Public Health Madison and Dane County, we are a local health department in Dane County in Wisconsin. So we follow those recommendations that are provided by our state, Wisconsin. The Department of Health Services allocates vaccine to the health systems and the local health departments based on availability of the vaccine, based on the population size, and cold storage capacity, because we're going to learn later in one of our sections about these mechanics of the vaccine. And Public Health in Madison and Dane County is, as I mentioned, following those guidelines and recommendations about the vaccine prioritization. We are in the distribution of phase 1A or tier 1A. That includes healthcare personnel, either that directly provide services to patients, they have contact with patients, or specimens, COVID specimens. And the other population that is included in this tier 1A or phase 1A are the long-term care facilities, residents and their staff. So in this first phase, in this tier 1 phase, the local health department has a limited role in the vaccine distribution because we provide services, we provide the vaccine to people that are not affiliated. I'm gonna just step back and not say people, but healthcare workers that are not affiliated with any health system, as Dr. Luna was mentioning. And to give you an idea of what that looks like in Dane County, for example, we calculated that in this first phase, in this tier 1 phase, there is about 34,000 healthcare workers. And from those, there are about like 22 to 24,000 that are inside of a major healthcare system. So those people will receive the vaccine through their employer, through the health system. And then the other part, the 10 to 12,000 people that are unaffiliated will receive the vaccine through the public health department. Another component of this tier 1A process, we talked about long-term care facilities also being included in this first phase. There is a program, there is a partnership program with the pharmacies, and they are providing the vaccines for the long-term care residents. And they're doing that distribution. So like we are doing a very similar approach. This is being rolled out in, like the same way nationwide. We are not all having, because of the size of our counties and the size of our healthcare personnel, not everyone is moving in the same way, but the rollout is being like the same across the nation.
Thank you so much for answering my question. I've heard a lot about phases, so phase 1A, 1B, 1C, but who decides, or how do you decide when to move on to the next phase? Like what percentage of vaccination is high enough?
Okay, so I can start with the question. And these frameworks were designed by our national academies just to look and make sure that everybody has equal access to healthcare, especially those voiceless, the most vulnerable. And we're talking about, like, let me just mention it because we're not giving enough media attention, but we're talking about undocumented individuals. We're talking about our refugees. We're talking about people living in shelter, homeless, those uninsured. So those which have less access to healthcare. And then in our Latino population and African American, because the mortality is so high, giving those disparities and those differences that exist, which are what comes out of systemic discrimination and racism that have been, embedded in the American institution in healthcare for years and years and years. So that is the idea of these frameworks. The one that we're following for this pandemic is pretty much led by the Advisory Committee for Immunization Practices. And this is pretty much what has been adopted to all the states. It's not only Chicago, it's not only Illinois. And we're pairing with IDPH, doing exactly the same thing. If IDPH changes or adjusts a little bit because there's a room for that, we're pretty much doing exactly the same so that people here don't feel that they have disadvantages. And as I mentioned before, the allocation of vaccines, and I think I didn't cover that. I'm going to cover it very quickly. And the initial allocation for vaccine from Pfizer, which was the first one that was approved for emergency use, was 63,000 for the city of Chicago. Of that proportion, after that, we started with Moderna too. Fortunately, we have now two industries or two pharmaceutical companies providing these doses of vaccination, but yet the doses are more limited. We went from 63 to then 11,000 from one, the other one a little bit more than that, and then from 37,000, now we're at 32,000. So that's a thing that outrages our mayor, that instead of getting more and more vaccinations go down very quickly to this prioritization list, it keeps us behind. But the other thing and the other component which makes it so relevant in this conversation today is that our healthcare providers are refusing to get the medication. And this is a big deal because we're leading the charts in mortality rate, we're leading the charts in positive cases, and yet our healthcare providers are refusing that vaccination for reasons that we can discuss later on. But this is something unacceptable because we are the ones who know of the benefits of the vaccination, and we're the leads and the champions in our community and ambassadors of health. And if this is the situation and the tone starting early in the vaccination process, what are the expectations for the rest of our population? So this is something that as I'm discussing with this group, because we're all here related to healthcare one way or the other, and it's our job to make sure that our population survives this pandemic.
Thank you for that. It's really important that we all get our vaccinations. And I want to hear from Dr. Shanjani how what we're seeing in Chicago compares to what you might be seeing in Madison and Dane County. Is it also the same where healthcare workers are refusing to get vaccinated as well?
Well, I can speak a little to those recommendations, how they're coming and how we're rolling out with our healthcare professionals. You know, as Dr. Luna mentioned, those recommendations are coming from federal and the state level, and the advisory committee on immunization practices create this series of grouping or recommendations for who should get the vaccine first. And then the CDC takes those recommendations and create those like tier. And both of them are looking at how to decrease death and serious disease as much as possible, how to preserve the functioning of our society, and how to reduce the extra COVID, the extra burden that COVID is having in the already disparities that we are seeing in the community. So as those grouping are creating, and just like to talk about equity a little bit, so people understand why this is happening. Like, why do we have groups of people and we don't start like just opening this up to everyone? It's because we're looking at those components and thinking about how much vaccine we currently have available. It is less than what we need to. So that's why we're having that like phased or tier approach. And then in our state, in Wisconsin, the Wisconsin State's Disaster Medical Advisory, the SDMAC, take those broader recommendations and then they formalize the definition. So who falls under those tier 1A or tier 1B? And we're gonna be talking a little bit about that too. So in our case, I talked about probably 34,000 individuals falling within the healthcare professional category. And so far as January 11, we have given about 25,000 doses in Dane County. So we still have a way to go before we get most of these people vaccinated and we can move into the next phase. I wouldn't say that we're necessarily seeing people rejecting to receive the vaccine, but we would like to have more vaccine available to move faster through these phases and get more people vaccinated. Every week we submit our request for vaccine, and definitely we're not getting as much as we would like to. We submit for a number and we do not get the amount of vaccine that we are requesting. And it's understandable because we also have to see how much vaccine has been allocated to the state and how much the state has to provide to us. So just like looking at that bigger picture too, is understandable that we do not have enough yet. Um, and we wish we would have more so we can move faster through these phases.
Thank you. So
very quickly, I just want to add that just to make those, to give a better picture of the vaxxers, refusers here in Chicago and the healthcare providers, because that's the only people we have vaccinated so far. From institutions have been reporting that the uptake of the vaccine is as low as 25%. And today we found out 20% in other places are refusing to get the vaccinations. African Americans as well as Latinos are falling down to 25%. So this is a big deal. It's mostly happening in nursing homes, and it's because we're getting those reports as we go rolling out the vaccine. And we're only 0.5% of our population vaccinated so far. And here in Chicago, it's been referred that 68% have received, 68,000 people already have received the vaccine. So this is where we're moving. We're very slow. And I agree, Lourdes, with the same situation that we're having a little bit of limited supply, mainly, but now these people, our people, our healthcare provider are walking away, leaving those spaces. We have our pots. And sometimes at the end of the day, we have cancellations, multiple cancellations. And that is very, very sad because we have to pull people from everywhere to give them the vaccine. We can't let these vaccines go to waste.
Thank you. We'll get more into why people are declining vaccination in the later segment, but I just want to touch a little bit on if we move faster through this rollout and we manage to get to more of a population distribution, how does having the need for a second dose affect the plan for vaccination, especially for undocumented or refugees or people who don't have a primary healthcare physician?
Yes, in Chicago, we're not there yet, but our plans are to, now that we start with our essential workers, we're expecting to get a lot of our undocumented. Hopefully everyone shows up. And we want to be sensitive because sharing sensitive information is a big deal in our undocumented population. And the mistrust of the federal government or La Migra. So those are things that really make this population so vulnerable. So the way that we have it is that they only need to provide a telephone number, probably, whichever number, just to call them for a second dose and to be very respectful with their name, addresses, and anything that could be a barrier for this population to walk in. And the same thing is with undocumented, they don't have to present. The vaccination is important that everybody knows is completely free. These are vaccinations under the emergency use authorizations by the FDA, which means they have been already purchased by the federal government. No individual in Chicago should receive a billing even 1 cent in relationship with these vaccines. So the word is out there. We want to make sure that it's something that resonates with our population, that they feel comfortable, that safety is not an issue or barriers to our vulnerables. And that's the same with refugees. If we need to send our strike team to our shelters or any of these institutions that most of our vulnerable population are located at, that is exactly what we will do. And then take the zip code of the place and we would know in ethnicity. We have been facing a lot of logistics problem, and it's because we're using iCare. Anybody that wants to go in there and become a vaccinator, they have an organization or their primary providers, and they want to work with our COA, with our pods, which are our clinics at the CDPH. They just have to fill all the information and go there. And at the same thing, any patient or any resident that receives a vaccine, there is what it's REDCap. So that's the electronic form that we have committed with the federal government to give all that information and keep track of where we at and what ethnicities are getting the vaccination. There was a lot of things, dirty data, institutions are giving the vaccine, but not uploading the information. And we don't want to make that a barrier to continue to provide and support with vaccinations, these institutions that are doing the job to the community that we want them to do. The CDPH has the same urgency. The city has the same urgency as anybody else to get this population completely vaccinated, our residents, all our ethnicities, and to move on and hopefully get the herd immunity that you have learn about, and have our people, like end this pandemic once and for all.
Yeah, I just want to follow up on that comment, Geraldine, because I believe it's important people understand that local health departments' responsibility is to ensure that all people, all the population is vaccinated and to help fill in the gaps so those vaccines are accessible to everyone. And that includes looking at the disparities and what barriers people may face in order to access, whether it is the first or the second dose. So what are things that we can do to help bring those barriers down? And another important aspect of that is communication and education in the community. So looking at collaborations where you can help disseminate information about the vaccine process, and you can also listen to what are the concerns of the community so you can help inform your communication and your processes better. So that is something that definitely helps to add for an equitable and ethical and transparent distribution of this vaccine. And, just like continue to work with different sectors like schools or other community partners as the vaccine becomes available to those sectors. So we can have that like information and that understanding, and people feel that they have the information that is needed to make the decision and to access the vaccine when it's time for everyone to get vaccinated.
Thank you so much. We do need to move on to the next section, but really quickly, I just want to ask one last question of what is the likelihood that community centers, churches, and libraries will be used as a vaccination distribution site to reach communities that are hesitant to go to the medical centers where they have a lot of mistrust? This question was asked in the chat, and just wanted to ask it to you guys now while we're on this topic.
Well, Chicago Department of Public Health are using exactly that. They're using colleges and the POTSNR at big hospitals, of course, and we have the infrastructure in place to receive Pfizer, which is a vaccine that we're receiving right now. We can have those extra cold temperatures to keep the vaccine stored. But yes, we agree and we know that. And as we roll out and open more and more, we have like 7 colleges right now, including Malcolm X, that are vaccinated healthcare providers. And we're preparing to move very quickly to 1B, which will open, we're talking about millions of individuals here in the whole in Illinois state that fall within that category. So yes, we're doing that. We understand that will give our most vulnerable residents that reassurance that they're walking into a safe place. There's no police, nobody to pull them out, and take them to La Migra or to any of these places. So that is something that we have in place, and it's working really well so far.
Thank you so much. And I want to give thank you to Nemo who asked the question, and we should move on to the next session, which is going to be held by Kelvin. So thank you so much for answering the last question.
Ready? Thank you so much for that, Erica. I'll be taking over for segment number 2. Before we get started, however, Dr. Zambrano wanted to do a brief presentation about the COVID virus and then also a brief overview of several vaccinations that have been developed.
Sure, thank you, Kevin. This is gonna take me only a few minutes, and I just wanted to go over exactly what different kinds of vaccinations we have available right now and exactly how they work. So there, the slide says 3 types, but really 4 types of coronavirus vaccines. And so we have on this left-hand side, the virus is like a sphere and has some spikes. That is the spike protein. So the virus uses that spike protein to attach to our cells, and then that's how we become infected. then once the virus is inside our cells, then it is gonna multiply. So the way we could develop immunity without getting the infection is through vaccines. And the oldest way is to have an inactivated virus being injected into our bodies, and then our body's gonna recognize that as foreign and develop immunity. And next time we see it, we already gonna know what it is and fight it. But there are three other ways. One is a protein base or protein unit. In this case, the spike protein, that could be presented to our bodies. We can develop immunity and then fight the virus the next time. Or we can have a purified gene that encodes for the spike protein embedded into another virus, the adenovirus, that is going to serve as transport. And then it is going to be delivered to our bodies. We're going to produce the spike protein based on that gene. And then our immune system is going to recognize it as foreign and develop immunity. And the last one would be, since we already know the genetic sequencing of the virus, take a little piece of mRNA, which is like a template. It's just a code, a single strand of a code that is gonna it's a template for a piece of the spike protein. And then if we present that to our body is gonna make that little piece of the spike protein, and our immune system is recognize it as foreign and develop immunity. So it's the specific companies working on these, and the inactivated virus, Sinovac and Sinopharm, in the next slide, are two Chinese vaccine companies, and they're working on the inactivated virus. Whole batches of coronavirus are grown, killed, and then made into vaccine. In the companies working on the protein subunits of the spike protein subunits are Sanofi and GlaxoSmithKline. They use the Flublok technology, the same one they use for the influenza vaccine. They also use baculovirus to grow little bits of the spike protein. They have been in phase 1 and 2 studies showing that their vaccine elicits immunity, especially in young adults, but the response wasn't as great in older adults, so new trials are gonna be started in February. Also, Novavax is a Maryland-based company, specializes in protein subunit vaccines. That is going to be in the next slide. And they use virus-like nanoparticles as a base covered with genetically engineered pieces of the coronavirus spike protein. We already have vaccines using this technology. Hepatitis B vaccine given to newborns, the human papillomavirus vaccine, and the Flublok influenza vaccine are all protein subunit vaccines. And then the other vaccines are the ones that are used an adenovirus as transport to deliver that spike protein gene into our cells, into our body. So we could make the spike protein and then develop the immunity. The Sputnik 5 is a Russian vaccine. They use the adenoviruses 5 and 26. And then the AstraZeneca, along with the Oxford University, another of the adenovirus vaccines. We should remember that the adenovirus is one of the common cold viruses, but this virus is not going to cause any harm to us because it's been already disabled. So it is the way to make these vaccines using these adenovirus is very cheap. So we're looking forward to AstraZeneca having these vaccine available. This vaccine could be kept stable for 6 months at standard temperatures. And so far it's shown to be 70% effective as in average. So for third world countries, countries in which the logistics are going to be very difficult, places hard to reach. So this vaccine is going to be very important. Then we have the Johnson & Johnson vaccine. Is also using an adenovirus, adenovirus 26. There is already a vaccine using this adenovirus 26 as a vector or transport, the Ebola vaccine. This Johnson & Johnson vaccine is a one-shot vaccine. So for people who were complaining about getting 2 shots, so this is going to be an alternative in the near future. Phase 1 and 2 in trials showed the vaccine produced good immunity in people, volunteers aged 18 to 55 and 65 and older. The company Johnson & Johnson is also testing a 2-dose regimen in volunteers to see if adding a second dose gets better protection and a longer lasting protection. And lastly, we have the mRNA vaccines. So Pfizer BioNTech, a German-based company, so they were able to develop these vaccines in only a few months, 8 months. So the makers of these vaccines already had the gene sequencing for the virus early in the pandemic. And they only had to get up a little piece of mRNA, which is the template. And by injecting that in our muscles, say in the arm, so that that code is gonna make our muscle cells to make with that template the little piece of the spike protein. So it is the muscle cells or nearby immune system cells also. They could produce the little piece of the spike protein. So our body's gonna recognize that as foreign, and then we're gonna develop the immunity. So the mRNA is just a little piece. It's a little template of a little piece of the spike protein. So it's a snapshot message that expires. It is not gonna become a permanent part of our bodies, as some people have suggested. These are just temporary messages, instructions for our cells to make this little piece of the protein. It takes about 25 different proteins to make a coronavirus. So having just a little piece of one protein is not gonna change anything inside our bodies. This mRNA piece is very fragile. So it needs to be encased in a lipid substance. Otherwise it's gonna melt down. So that's why this Pfizer vaccine needs to be kept refrigerated at minus 96 degrees Fahrenheit. That means that we need equipment and special fridges to transport and store the vaccine. The vaccine is shown to be 95% effective in clinical trials. And Pfizer is now working to show that this vaccine can prevent all infections, including those that do not cause symptoms. Side effects are mild, fever, headaches, muscle aches. A few people have developed severe allergic reactions to the vaccine components. The vaccine is given in 2 doses, 21 days apart, to all those who are 16 years of age or older. The second dose could be given at 21 days with a 4-day grace period. Could be given 4 days before the 21-day mark. If the minimal interval is violated, so it should be considered that the patient has been vaccinated, even though the data is not enough. And there is no maximal interval between the first and the second dose. The Moderna vaccine, the vaccine sponsored by the NIH, is another mRNA vaccine using the spike protein. And the spike protein was chosen because it doesn't mutate or change as much as time goes by. It does appear to remain stable through generations and generations of viral replication. This vaccine, Moderna vaccine, shown to be 94% effective in preventing symptomatic infections. And the company says that they have data showing the vaccine also prevented all infections, including those that do not cause symptoms. The vaccine is given in 2 doses, 28 days apart, to those 18 years of age or older. People vaccinated with these 2 mRNA vaccines, no one had died after, even if they were infected. So these mRNA vaccines are not interchangeable with each other. So if you get the Pfizer vaccine the first time, you have to keep with that one. And also you cannot get any of the other vaccines we mentioned interchangeably. These mRNA vaccines should be administered alone. You should wait at least 14 days before you use any other vaccine, 14 days before or after. And finally, the last slide is in regards to the ingredients. In these two mRNA vaccines, they of course have the mRNA piece and the lipid cover. The polyethylene glycol is the main one. Some people are allergic to that component. It is a component in other medications and also and PrEP for colonoscopies and things like that. So some people have been sensitized with that component. The vaccines have salt and sugar, more so on the Pfizer. And so the labels saying that people should be made aware if they're allergic to any of these components. There are no preservatives or latex in these two vaccines. So I'm gonna stop right there and see if there are any questions.
Great. So thank you so much for your presentation, Dr. Zambrano. So this segment was basically meant to address the medical implications of the vaccines and then also address certain common questions that patients might have or providers might have about convincing their patients to get the vaccination. So we talked a little bit about the mechanism of action of the different vaccines. We know that Moderna and the Pfizer vaccines, these are the ones that I'm sticking to, those are the ones administered in Chicago. They are mRNA based. So is there any difference between the two that should concern patients, like a particular allergic reaction, or would one be a better fit for a certain type of patient than the other, or how does that work?
Yeah, I don't think there are really major differences. There's a little bit of differences in the components. If somebody is allergic to one of those components, they should pay attention to and read the components before they get the vaccine. But other than that, they are pretty much the same.
Alrighty, and then the next question I wanted to ask, are there any side effects? Like you mentioned that a couple of the ingredients might trigger side effects, but the actual vaccinations themselves, should any particular type of patients be concerned about getting them?
Yeah, so people complain about getting a sore arm. Some others, a little lymphadenopathy in the armpit. And most people say that 24 hours later, in my case particularly also, I felt like a little tired, a little bit of muscle aches maybe, but that was about it. And they went away within hours. Some other people have reported fevers, headaches, and the side effects that people are most afraid of are allergic reactions. There are a number of allergic reactions related to the vaccines, anaphylactic reactions. So if people have reacted to any of the components of those vaccines, they should not get the vaccine. If they had an allergic reaction to any other vaccines, they should be watched closely while getting these vaccines. And there are protocols already in place, exactly what to do and how to screen people for possible allergic reactions.
Alrighty, and then if you have a number available, about what percentage would you say of patients that have been studied have had an actual adverse reaction? Is it few, like a lot? Like, how would you describe it?
Yeah, so there are people developing allergic reactions to all vaccines. And there seems to be a little more with these ones, but we are given, say, I think there have been so far less than 15 cases of severe allergic reactions and given millions of doses already. So nobody has died from any of those severe allergic reactions. So there is, it is part of the side effects and the potential issues with the vaccine. And it is probably more so than any other previous vaccines, but it's still a very low number compared to the number of millions given.
Alrighty. And so with this, there's been a lot of talk about genetically mutated versions of the virus that have been found both here and abroad. So I wanted to ask you about the current vaccines that we have available. Are they effective against those mutated strains, or is there a little bit of difference?
Yeah, it seems to be that there's a new variant of the coronavirus, and it seems to be that these vaccines, these mRNA vaccines, are gonna protect us from those variants as well. But I said in the future, the virus mutates a little more. The technology is such that they could tweak the vaccine a little bit, the mRNA, and that could make it enough to cover whatever strain is around in the area.
All right, and then with the studies on that, how long is the vaccine active for? Are they going to have to get another shot in 6 months? Is it immunity for the entire year? Like, how long does it last?
Yeah, so it seems to me that the vaccine is going to cover us for at least a year, hopefully longer, but at least 1 year. So we're going to have to, I mean, there are going to be studies still ongoing. Pfizer and Moderna continue to do studies and see. We may need a less amount of the dose, not the full amount. We may need only 1 shot instead of 2. So they continue to test different options. But so far, at least 1 year, hopefully more. And then in a year from now, we'll see what is going to happen with it. We're going to need a booster or another series of the shots. Yeah.
Ready. Thank you so much for answering my questions. In the interest of time, we'll be moving over to the next segment, and that one is going to be presented by Yanina.
Thank you.
Thank you so much, Dr. Zambrano. Hi, my name is Janina. Again, so this section that we're going to be doing is about common myths. And so this will be directed in Spanish. And it will be for Dr. Shanjani, Dr. Luna, and of course, Dr. Zambrano. So anyone is welcome to answer. If you do not speak Spanish, we will be able to translate it through the question and answer chat. So please let us know in the chat if you do need translation. Okay. Pues la primera pregunta que tengo es, ¿has escuchado estas teorías falsas de la vacuna? Me van a poner un microchip con la vacuna. ¿Cómo deberíamos responder a estos falsos teorías?
Yo quise, pues, yo mencioné también en esto del el RNA mensajero, que es solamente un pedacito y es algo que es temporal, es algo que lo inyectan en el cuerpo de nosotros y nosotros lo usamos como un modelo para crear una proteína, pero rápidamente eso se va, es algo bien temporal y no se queda dentro de nuestro cuerpo. O sea que es imposible que con esta vacuna tengamos ningún cambio permanente, porque lo que están inyectando es un pedacito mínimo del virus y es algo que es temporal, que simplemente lo vamos a usar como un modelo para crear para que el cuerpo nuestro cree la proteína y ya eso se va, ¿no? Desaparece. O sea que lo del microchip, eso no tiene realmente ninguna base en la realidad.
Algo que me gustaría agregar, Janina, bien rapidito, es que es importante como proveedores de salud que nosotros tengamos también la sensibilidad cuando estamos hablando con nuestros pacientes de entender que estos mitos o estas creencias que hay en la comunidad, no solamente en nuestra comunidad, pero en comunidades, tiene que ver mucho con cómo las ideas o la comunicación se maneja en nuestras comunidades. Entonces, tener esa sensibilidad también cuando estamos pasando información, cuando estamos tratando de educar a nuestros pacientes, educar a nuestros clientes y hacerlo de una forma que sea sensible, sin que la persona se sienta que estamos juzgándolo o juzgándola o juzgando. y que estamos ahí para entender y para aclarar las dudas que las personas, que nuestros pacientes pueden tener.
Muchas gracias, Lourdes. La pregunta que quiero preguntar es, algunas personas piensan que mucha de la gente se enferma por la vacuna y muchas se han muerto. ¿Cómo deberíamos responder a estas preguntas o teorías?
Yo creo que el doctor
Sí,
Zambrano nos... por favor, Geraldine.
Sí, y Carlos, siéntete a gusto de brincar en cualquier momento y
Oh,
ayudarme
gracias.
aquí, pero sí, la vacuna, enfermarse de la vacuna no tiene partes del virus, no tiene el virus vivo, no tiene el virus atenuado, lo que tiene es un ARN mensajero, y esa tecnología lo que hace es que lleva el mensaje de una pequeña proteína, como dijo el doctor Zambrano, que se encuentra en la cápsida del coronavirus, que lleva ese nombre de coronavirus porque tiene esas espículas, y de parte de esas espículas es ahí donde vemos que esa proteína es la que se logró capturar en esta tecnología. Así que la vacuna no se asocia a enfermarse con el COVID-19. Las personas sí podrían enfermarse y morir de sufrir de la enfermedad del COVID-19 si no nos vacunáramos.
Sí, es cierto. Hasta ahora no se han muerto de las personas que han recibido la vacuna. Aún si se contagiaron con la infección, nadie se ha muerto. O sea que protege de todas maneras, prevenir la infección, pero también si uno adquiere la infección, también lo protege porque no va a ser tan severa que vaya a causar la muerte. Y cuando evalúan la cantidad de, por ejemplo, hay gente que dice que recibieron la vacuna y alguien tuvo un ataque al corazón unos días después, pero cuando examinan el número de personas de esas edades que tienen ataques al corazón o algún otro problema de salud, más o menos viene siendo el mismo porcentaje de personas. Entonces es difícil atribuir que la vacuna esté causando esto o lo otro. Indudablemente que todos los efectos secundarios que se vean o problemas de salud grandes que las personas tengan, todo eso se va a investigar para ver si de verdad hubo alguna relación con la vacuna o simplemente es parte de lo que las personas sufren a través por la edad y por todas las enfermedades concomitantes.
¿Y qué tal una mujer que está embarazada o que está dando pecho puede poner la vacuna, o hay efectos que puede causar que puede doler a la mujer o al bebé?
Pues esa es otra, la situación es difícil. La recomendación hasta ahora es que las mujeres embarazadas discutan con sus médicos primarios, con sus obstetras, exactamente cuál sería la mejor forma de evaluar esta situación. Durante los estudios que hicieron con las vacunas de Pfizer y Moderna, no trataron de reclutar personas en embarazo, pero algunas de las mujeres durante el periodo del estudio quedaron en embarazo y no tuvieron problemas mayores. No hay suficiente información, entonces, ¿qué va a pasar? Y tienen que evaluar las personas los beneficios y los riesgos de recibir la vacuna, especialmente si las mujeres ya han pasado el primer trimestre del embarazo. De pronto se sienten más confortables recibiendo la vacuna. Y si quieren protegerse ellas porque van a estar expuestas o van a exponer a los miembros de la familia que tienen enfermedades concomitantes, también es algo que las haría inclinar más a recibir la vacuna.
Sí, Carlos, yo estoy completamente de acuerdo, no lo has podido poner en mejores palabras. También se ha visto que las personas embarazadas están a muy alto riesgo de la presentación severa del COVID, y también hay riesgo de tener parto prematuro con su bebé. Así que la protección, por lo menos el Comité Asesor en Prácticas de Inmunización recomendó que las incluyéramos, especialmente si son empleadas de la salud pública, si están a alto riesgo, si están en la lista de priorización y van en ese camino y todavía no han tenido el parto, se les recomendó que se vacunaran. Aquí el Departamento de Salud Pública asume esa posición que tú has mencionado, doctor Zambrano, que es hablar con los ginecólogos, pero de que protege contra el COVID-19, sí protege, y la presentación del COVID-19 es bastante severa en este grupo vulnerable.
Muchas gracias, doctor Luna, y también doctor Zambrano. La última pregunta, ¿cómo es que la vacuna se hizo tan rápido? ¿Se saltaron los pasos de los ensayos clínicos?
Sí, yo puedo ayudar con eso y el doctor Zambrano y la doctora Shanghani pueden también ayudarme con eso. Pero no, las personas tienen la sensación de que esta vacuna se hizo de 12 a 18 meses y mientras que otros productos, vacunas anteriores, otros productos de Pfizer, les toma de 10 a 20 años sacar el producto al mercado aprobado por la FDA. Sin embargo, el ARN mensajero, esa tecnología ya existía antes de la presentación del COVID-19 y la presentación inicial del SARS, en este caso SARS-2 es el que vemos ahora, SARS-1 está... Ay, discúlpeme, el SARS-1 lleva ya desde el 2002, ya lleva, toda esa data científica estaba en el momento donde se presenta el COVID-19. Normalmente las farmacéuticas absorben lo que es el research and development o el desarrollo y los ensayos clínicos solos, pero como estábamos en medio de una emergencia, en una pandemia, se abrió a la colaboración de científicos alrededor del mundo y academias que eran expertas en este sistema y en esta tecnología, y entonces llegaron a la conclusión y pudieron hacer la ingeniería de esta vacuna, pero no es tan rápida, es riguroso, los procesos eran rigurosos como cualquier otro producto que se manufactura para el uso del público aquí en los Estados Unidos y en el mundo entero, y no se brincó nada, los mismos escrutinios y todas las fases se aprobaron como era debido, así que la vacuna es muy segura. Doctor Zambrano y doctor Shanghani se los...
No, yo creo que tú lo explicaste súper excelente, doctora Luna, pero algo que también nosotros podemos enfatizar es en la seguridad que la vacuna tiene y como decía el doctor Zambrano anteriormente, si hablamos, por ejemplo, de las reacciones adversas que las personas están presentando, de millones de personas que ya han recibido la vacuna, menos de 15%, de 15 personas, perdón, no 15%, 15 personas han presentado esas reacciones adversas severas. Hablando de esa seguridad, hablando de la eficacia de la vacuna también, que está sobre el 95%, creo que ahí es donde nosotros debemos de enfatizar la conversación para hacer que nuestros pacientes, nuestros clientes se sientan más cómodos y se sientan más confiados en cómo se desarrolló la vacuna y la seguridad y la efectividad de este producto.
Cierto. También añadir que la Moderna había estado trabajando en este tipo de vacunas con RNA mensajero por un periodo de 10 años. O sea que era una tecnología que ellos venían perfeccionando. No habían tenido ninguna vacuna en el mercado, pero ya la tecnología la tenían muy bien estudiada y fue algo muy rápido porque el sistema de desarrollar la vacuna muy sencillo. O sea que la parte científica bien, de la parte administrativa trataron de cortar esas partes administrativas, pero la parte científica siguieron las mismas fases 1, 2 y 3 para saber que era segura y que era efectiva en prevenir la enfermedad.
Muchas gracias. Lo que vamos a hacer ahorita, or what we're going to do now, is we're going to jump over to the question and answer that you all came up. If there's any burning questions that you may have, Jennifer, one of our moderators, collected them. So I'm just going to go over to Jennifer.
Okay, thank you. So we did have a couple here. One of them is written in Spanish, but whoever wants to answer, you can go ahead and answer in both English or Spanish, either or. So the question was, ¿se ha notado alguna relación entre los efectos secundarios de la vacuna y su incremento en pacientes con diagnóstico de migraña?
Yo realmente no tengo ninguna información. La vacuna tiene como efecto secundario dolor de cabeza en casi la mitad de las personas. Pero en cuestiones de migraña no tengo ninguna información. No.
Yo tampoco he visto ningún estudio relacionado al incremento de la migraña o personas con diagnóstico de migraña y la relación con la vacuna. Entonces, creo que también sería algo que vendría más a medida que se abra más el proceso de vacunación, se vacunen más personas y ver también cómo las personas están reaccionando y haya más estudios en relación a eso, es lo que me parece.
Okay. Buenas tardes, mi nombre es María, esa fue mi pregunta y la razón por la cual la hice fue porque, claro, quería saber más de la experiencia que ustedes tienen, que es amplia, pero en la clínica donde estoy rotando ahorita han llegado 2 pacientes con diagnóstico de migraña que tuvieron síncope después de la primera inyección. Y llegaron luego 3 pacientes con diagnóstico de migraña que han tenido severos ataques de migraña seguidos que no habían presentado anteriormente. Y fue justo después que se pusieron la vacuna. Entonces, solo como que quería aclarar la duda y saber si había como alguna relación, pero sí es muy pronto para saberlo.
Muy interesante la pregunta. Y seguro que esas personas la van a reportar, ¿no?, al sistema del CDC, del VAR, para todos los efectos secundarios, que vamos a estar aprendiendo mucho más. Otras personas también han comentado que tienen dificultad con el sueño, que cambia el ciclo del sueño y ahora tienen insomnio, están tomando melatonina y esto. Pero todos esos son reportes que están saliendo cada día y en algún momento se van a agregar y vamos a poder mirar qué tan significativo es el porcentaje de cada uno de esos efectos. Sí, muchas gracias por compartir. Sí.
No, muchas gracias a ustedes por la respuesta.
Okay. The other question that we have, I believe this one comes from Cesar, and it's about when should we expect an approval for other vaccines like the AstraZeneca or the Johnson & Johnson vaccine? The first one having a better storage and distribution capabilities, and the second one requiring just 1 dose.
Creo que la de Johnson & Johnson va a tener un poquito de tardanza ahora. Un delay for the Johnson & Johnson. I think they're going to until February. But the AstraZeneca, it is in the process. So that one is going to be faster than the Johnson & Johnson.
Okay. All right, thank you. And then I know, Dr. Katia Madrid, I know you mentioned something about facial paralysis. Is there what is the question you want to ask with that?
Ha habido unos reportes anteriores de parálisis de Bell, que es Bell's palsy, and weakness on one side of the face. And initially there were some reports of less than a handful of people with Bell's palsy. But again, when they analyze the percentage of people in a period of time and in an age group that develop Bell's palsy for whatever reason or no reason, it is not that much different than the ones that receive the vaccine. So far they haven't found that there is a cause and effect that the vaccine causing the Bell's palsy, but they were reported a number of cases during the trials, the trial period for the vaccines.
Thank you. And let me see. Yeah, so I believe we don't have any more other questions other than the ones that were already answered by the presentation. I don't know if anybody else has any other questions they would like to ask before we end.
I just have a comment if there is no other questions at the moment. And what I want to say is that we're talking about vaccines and we're talking about this being a way to end the pandemic, right? But we also want people to think about this is something that gives us hope about going through this pandemic and possibly ending it, but it is not the only thing that is going to help us end that. So just like continue encouraging your patients and people you work with to maintain those protective and preventive measures of maintaining distance and washing hands and using the face covering, because it's going to be a while until we can get the entire population vaccinated to the level that we can have that community immunity. So just like, let's look at that light at the end of the tunnel, but like recognize that we still have to go through that tunnel and we still need to continue maintaining those measures.
Thank you. Okay, yes, so I don't see any more questions in the chat, but thank you all for coming to this event, and I would like to thank all of our speakers and all of our wonderful moderators. We will, if we have the permission from the presenters, we will be sending you some extra information, maybe the presentations as well. And if you are a MOLA member and you are receiving the vaccine, please send an email to contact MOLA. We will be generating an entire collage about all of our members getting vaccines. So thank you very much and have a good night, everybody, and stay healthy. Thank you.
Thank you.
Thank you, everyone.
Thank you.